This presentation will cover psychosis and mood disorders, specifically schizophrenia and bipolar disorder. I'm Bethany Von Hoff, and I will be the presenter for this presentation. As you may be starting to gather from the presentations in Section 3 related to psychiatry and neurology, these are all very complicated medical conditions to treat, and psychosis, schizophrenia, and bipolar disorder are no exception. Again, we are just going to be providing a very brief overview of these areas. Psychosis can be especially helpful to learn as it is often considered the bookend in understanding the mirror image of Parkinson's disease, which we also cover in this section. Also, many of the antipsychotic agents are now being used for patients who only have a diagnosis of depression, so you may be seeing more of these agents more frequently in commercials, out in the community, especially because we have a lot of social work students who take this class. These agents may be seen quite often in your patients. In our everyday language, we seem to use the word psychosis, mania, or things like he was acting psychotic or she was acting like a maniac interchangeably to mean the same thing. So it can be difficult to separate what the technical definition of these terms are versus how we often use them in daily conversation. So this slide provides some of the technical definitions for these and other terms. You can see that psychosis is related to a defective or lost contact with reality, often including hallucinations or delusions, whereas mania is noted by hyperactivity, disorganization of behavior, and an elevation of mood. If you've already listened to the presentation on Parkinson's disease, then the easiest way to think about psychosis is that it's the opposite of Parkinson's. In Parkinson's, you have too little dopamine, and in psychosis, you have too much dopamine. So many of the strategies we are going to be using in treatment of psychosis is to primarily block the excess dopamine and to minimize the effect of this extra neurotransmitter that's circulating in the brain, and also try to quiet the brain during periods of hyperactivity. This picture demonstrates the primary areas of dopamine and serotonin in the brain where we target the effects of excess dopamine. From the Parkinson's lecture, remember that it is the lack of dopamine in the nigrostriatal areas of the brain that cause the movement disorders associated with Parkinson's. When we give extra dopamine, sometimes that spills over into the mesocortical limbic areas that can cause some of the psychosis symptoms we see in patients being treated for Parkinson's. The opposite then can happen in patients being treated for psychosis. If we are trying to block excess dopamine in the mesocortical limbic area, we may also block some in the nigrostriatal area and induce a movement disorder. So if you can sort of think about psychosis and Parkinson's as being opposing to each other, that may help you remember both of them. It's not a perfect match, but it may help you as you think about and learn about these disorders. Schizophrenia is maybe more common than you expect, with just over 1% of the adult U.S. population having a diagnosis of schizophrenia. The first episodes often occur earlier in men than women. Typically, men will have their first episode in late teens or early 20s. The symptoms of schizophrenia can be divided into three main categories: negative, positive, and cognitive symptoms. We will talk about them more in more detail on the following slides. A positive side effect doesn't mean that it's a good side effect. A positive side effect means that something new or additional is showing up for the patient. This is often things such as hallucinations or delusional beliefs. Negative side effects, on the other hand, is a lack of something that should be there. So this often includes things like a lack of emotion or a dull voice tone. The final category is cognitive side effects, so this includes things such as memory problems, poor attention span, and difficulty processing information. Strategies and agents used are broken down into typical and atypical. The typical products are often called neuroleptics or tranquilizers, and those work by blocking the dopamine D2 receptors, and the two classic examples are Thorazine and Haldol. Especially Haldol, you may have heard before on medical TV shows or movies. These medications can be quite potent, and they're often used to control patients who are in the middle of a crisis situation or event. They tend to be very sedating and do induce a chemical control over the patient. The side effects of typical agents tend to be related to the blockade of other receptors that are also targeted by these agents. For example, you can see that there's anticholinergic side effects because these agents can block muscarinic receptors. We've covered most of these receptors in other presentations, so you should be somewhat familiar with these receptors and what their related side effects are. There are some other side effects from these agents, such as photosensitivity from Thorazine, so that means being more sensitive to sunlight, and there's also the potential for a lowered seizure threshold. One of the biggest worries we have with the use of typical antipsychotic agents is the extrapyramidal side effects, or EPS. As we talked about earlier, sometimes when we block excess dopamine, we can also block dopamine in the nigrostriatal area, which we don't want. We are trying to block the excess dopamine in the mesocortical limbic area, but when we block it in other areas, we can induce these movement disorders. These can be severe, debilitating kinds of movement disorders that many times are not reversible. If a patient has a permanent movement disorder, this is a very serious adverse effect. These movement disorders can have an early onset or a delayed onset. So with the delayed onset, you may often think that the patient is doing well on the medication, and then they may still develop a movement disorder later on. The atypical antipsychotics, also called the second generation antipsychotics, use a slightly different strategy than the typical agents. They are still working by blocking dopamine, but in a more targeted way, and so there's less spillover, and so there's less blockade of the dopamine in the nigrostriatal area, so a much lower incidence of the extrapyramidal side effects with these agents. Some examples are Clozaril and Zyprexa. While the atypical agents have a much lower incidence of EPS than compared to the typical agents, they still do have side effects and adverse events. Many of these agents can be sedating, but again, so are the typical agents. There can also be cardiac events with these agents. Additionally, there can be significant weight gain that can occur, and it also appears that there's a stimulation of type 2 diabetes on patients taking the atypical agents. So it can be common for patients on these medications to gain a significant amount of weight and also to develop type 2 diabetes. This slide shows the relative sedation of the atypical agents, with Seroquel being at the top being the most sedating, all the way down to Abilify at the bottom, which actually can be stimulating for patients. Occasionally you'll see providers using Seroquel only for its sedating property to help people sleep, but this isn't really a great use of the medication, and there are other agents to use first, unless the patient also has comorbid psychosis, in which it might be useful to use it for both reasons. There is a unique and serious side effect from one of the atypical agents, Clozaril. Clozaril can cause agranulocytosis, which is a severe drop in the white blood cell count, which can be fatal if it is not recognized fast enough. So patients who use this agent have to have blood cell counts monitored weekly for the first 6 months, then every other week for 6 to 12 months, and then usually monthly thereafter. Because of the risk associated with this medication and the increased monitoring needed, Clozaril is reserved for patients who have not responded to other therapies. We're going to switch gears a little bit now to talk about bipolar disorder. This is also a common mental illness with the prevalence as high as 5%. The typical onset of first symptoms is usually in the late teens and early 20s. We don't really have a full understanding of what causes bipolar disorder, although there seems to be a strong connection with family history as well as environmental components such as stress or seasonal changes, which may worsen or trigger onset. It's believed that a serotonin imbalance is primarily involved with the depression phase of bipolar, and that a dopamine or norepinephrine imbalance is involved in the manic phase. This slide is mostly just an FYI that there are a lot of different kinds of bipolar with different classifications. So bipolar, even though we often just say bipolar disorder, it's not just one disorder, but there can be several distinctions and classifications within the bipolar diagnosis. When patients have bipolar symptoms, they can have a variety of different symptoms and actions depending on which phase that they are in. So bipolar is between kind of a manic stage and a depressive phase. And you can see there's a lot of symptoms listed on this slide. Under the major depression, I'll just have you refer to the depression presentation because when the patient is in the depressive phase of their bipolar disorder, they have many of the classic depression symptoms that we've already talked about. When they're in the manic phase, they can have symptoms that can be schizophrenic-like, including racing thoughts, hyperexcitability, and poor judgment. And then in the middle is this hypomania, and that's kind of a low-level mania where there's no marked impairment in the social or occupational functioning, no delusions or hallucinations, but it still can mimic some of the symptoms of mania. Bipolar disorder can have some serious health outcomes, and patients who are untreated have a much greater increased risk of suicide and accidental death during the manic phase. Patients can often feel invincible in the manic phase, and all ideas may seem like a good idea, so they may participate in reckless activities, and accidental deaths are not uncommon. Many patients can also lose their jobs or have to drop out of schools. Bipolar disorder can also put a lot of strain on family and friend relationships. So there can be many consequences if bipolar disorder is left untreated. The gold standard for treatment for bipolar disorder is lithium, and while it works really well, we still don't exactly know why it works, but it's been found to be a very effective agent for the treatment of bipolar disorder, and if it's given to someone who does not have bipolar disorder, there is really no effect in these patients. The drawback to lithium is that there are a lot of side effects and it is very effort intensive because you have to monitor blood levels to ensure that the agent is being efficacious without being toxic. This slide also includes some of the other minor, less serious adverse events as well as some of the more serious ones associated with the use of lithium. There are also additional concerns with the use of lithium in pregnancy. In addition to the adverse effects of lithium, there also can be drug interactions depending on the patient's kidney function and other medications. So medications that may decrease the renal clearance could lead to lithium toxicity because of a decreased clearance of the medication. On the other hand, things that can increase the renal clearance could lead to a decreased efficacy of lithium because too much is getting cleared at a faster rate. Despite the fact that lithium can be very effective for bipolar disorder, often other agents are used, and they're often used in combination of different products. So anticonvulsants, particularly Depakote, is effective for the manic phase of bipolar disorder, and antidepressants work well for the depressive symptoms. It's really important, though, that antidepressants are not used alone for bipolar disorder, as some antidepressants can trigger that mania phase if they're just being treated with the antidepressant. Benzodiazepines can also be used for the insomnia associated with the manic phases or for the agitation associated with the mania. And then finally, some atypical antipsychotics can be used for some of the psychosis symptoms associated with mania. So this slide summarizes some of the reasons why you might choose a typical versus an atypical agent. So the atypical agents are generally preferred because they have a more convenient dosing schedule and they have that lower incidence of EPS. A downside of the atypical agents is that they can be expensive, although most of them now are available generic, so this is getting better and less of an problem. Some of the benefits of the typical agents is that they're less expensive, but if something is cheap but required to be dosed 4 times a day and a patient can't take it 4 times a day, it doesn't really matter how affordable it is. And then finally, Clozaril is reserved for just those refractory patients who aren't responding to other agents. We're going to include this one slide about the difference between delirium and psychosis because this is another example of terms that get thrown around interchangeably in conversation. So delirium is real, but it is different than psychosis. So delirium is a medical condition that can be caused by some kind of substance intake of a substance of abuse or from a medication use or medication withdrawal. Delirium can have often psychotic-like symptoms and it might look like psychosis, but the difference is that delirium will come and go and that it will wear off once the issues have been resolved, such as if it's being caused by a medication. Once that medication is discontinued and out of the system, then the delirium will go away. Delirium can be very common in ICU patients or critical care situations, and this can be dangerous because if patients aren't thinking properly, they can have a skewed and inaccurate view of what's actually going on, and they can potentially hurt themselves. It seems that especially the elderly patients are at more of a risk of delirium. So finally, this is just a summary slide of some of the agents we talked about and common examples of each of the categories that they fall into. So again, the atypical common ones being Clozaril and Zyprexa, typical agents being Thorazine and Haldol, and then lithium being the most common example for the mood stabilizer.